Hey everyone, before this week's content, I have one ask of you. I'm in the process of building out something to really change the game around continuing education. With that said, I need your help to make sure it best meets your needs and solves the problems you're facing day to day in the clinic. It would mean the world to me if you could jump on modernpaincare.com/community and let me know what you would like to see built out to best meet your needs. It will only take about 5 minutes and I'd greatly appreciate it. Now on to the content. Welcome back to this week's episode of the Modern Pain Podcast. Have you felt a bit lost on where manual therapy fits in pain care? If you look at social media, sometimes it's either it sucks or we should be using it all the time. So where's the nuance in that conversation? I know I definitely have had moments where I questioned its place in my practice, and even if it had a place at all in some patients. This week, we'll talk with Erson Religioso, or better known as Dr. E. The episode felt a bit like a support group meeting as we shared stories of the traditional old school theories that we had to let go. We also share stories and how our practices have changed over time to put manual therapy in a more person-centered position. You're going to leave this episode with a better feel for where manual therapy may fit in your practice and hopefully see a little bit of your own journey in the stories that we're going to share. On to the episode.
This is the Modern Pain Podcast with Mark Cardula.
Erson, welcome to the podcast.
How's it going?
Oh man, good, going well. I just had another podcast recording before this. Feel like I'm busy as I'll get out chatting with people, but they're great discussions, and I'm looking forward to having another good discussion with you. I'd been on your podcast a couple weeks ago. This is, and who knows when people are listening to this, it might be a year or two ago, but and really enjoyed the episode. Obviously, we've shared some similar journeys, and we'll touch upon that today. But for folks that don't know Dr. E, I mean, I know most of our audience probably know of you.
I hope so.
Yourself,
but yeah, I mean, if they don't, I'm hoping they don't actually.
This could be an introduction to you, and maybe something that'll generate some interest, because it's definitely you're somebody who I've really enjoyed your perspective on things, and I know you teach some good stuff. So, but anyway, let's talk about kind of your journey, like where you're at right now, what you're up to, and maybe we'll get into some further things about your development over some time.
Sure. Well, I graduated 26 years ago at this point, so it's been quite a journey. And I graduated with a BS-MS, and there was no even transitional DPT way back in 1998. But I wanted heavily to get into manual therapy. My ortho professor was he's a manual therapy fellow and also very big in the McKenzie Institute, Dr. Ron Schenk. So he was my ortho professor. He agreed to be my mentor. And I thought, I had this roommate who was also really into manual therapy, and he said, "Hey, let's become chiropractors." And my parents, as medical doctors, had said, we'll basically disown you if you become a chiropractor. And nothing against chiropractors, but chiros and medical doctors, at least old school chiros and older doctors, I mean, MDs ran like a smear campaign against them, and about like the Committee on Quackery or whatever. We learned all this stuff in like the history of manual therapy in St. Augustine, right, Mark?
Yes, we did. Yes, we did.
Which is why they started calling it adjustment instead of manipulation, because they thought manipulation was like literally a manipulation of your mind rather than a medical term. It sounded anti-medical, so they started calling it adjustment. And so my parents did not like that idea. And I remember on my last clinical, I was speaking to a guy who wasn't my CI, but he was the head of the rehab department. And I said, I really want to get into manual therapy, but my parents are kind of against, and by manual therapy, I really meant spinal manipulation. Cause to me, that was the only thing there was about manual therapy. It was just about more cracking, less yakking, more cracking. Right. And he said, "Hey, have you ever heard of Stanley Paris?" And I was like, "Who's that?" And I remember he put like the PT journal in front of me, opened it up to whatever, probably page 2 or page 1 or something, I don't even know. Do they still have it used to be like a picture of Paris, and black and white picture of Paris in the top left corner, 2-page spread, S1, S2, S3, S4, E1, Surfic MTC. I'm like, oh, what's this? So I contact them, and that was around, say, December of my final year. By the time, and I was really interested. So I kept that in mind. And right around the time, like between April and May, right as I was about to graduate, they had announced that they started a manual therapy residency program and a DPT. And it was like one of the first DPTs in the nation. Transitional wasn't even a word yet. This was 1998. So I applied the week I was graduating, and I got in and I started the program 2 days after I graduated. Like I graduated on a Friday, took 2 days off, and immediately started working with my mentors. My mentor, my ortho professor, said, "Hey, I'll be your mentor." So he got me a job at the hospital. He was working at the residency rate, which meaning at that time, whatever, I don't know, it was agreed to be like 70% of what a PT makes, but you still work full time. And so I got all my hours there. Then I flew down to St. Augustine like every other month. I took all the courses, got my MTC. Um, just I loved all the minutia you could pile on. Like the more minutia, the better. And it was funny because if you remember, I don't know, when I took S1, it was 5 days. I know people were like, "Oh, it used to be 10 days," and I'm like, "Man, I thought 5 days was long." Can you imagine taking 10 days?
Good God, no.
I know,
cannot.
like even when I teach my 2-day weekend course, people start to like check out at like the second day after lunch. They're already like, "Wow, you guys, you were practicing for like 15 minutes, and now you're like practicing for 2 minutes, right?" Everyone's already asking, even at the beginning of the second day, like, "Hey, if we start early and we cut lunch to 50%, can we get out early?" And this is 10 days, right? So it was 5 days, and then the next course was like 4 days. The next course was 3 days, and the funny thing was, I didn't like it at the time. I could not appreciate it, but the more advanced the courses got, the less assessments and less techniques there were. Because in like the first couple courses, S1 was like, "Hey, here's 500 ways to passively assess someone. Here's like the same assessments in side lying, prone, and supine. And here's the same cervical assessments in side lying, and supine, and prone," right? Like it's just now after those 500 ways to assess someone, here's 1,000 ways to manipulate them, right? And I was just like, wow, the more the better. And I didn't really realize at the time that you come back on, well, not even, I don't even know if you come back on Monday, because I don't even know, was it one day? I don't even know, was it like Monday through Friday? So whatever. The next Monday, you kind of think, well, now what? Right. And that's really what it was. Like, well, I think I have an idea what to do. I'm just going to start like what I call poking and hoping, or pressing and guessing, you know? There's not really like and even if you really affect someone, all these traditional programs had, all it was just like assessment and treatment, assessment and treatment. And there's like cursory exercises, right? Maybe like an appendix of exercises that they may suggest. Because ultimately, I don't know what the modern residency program is like now. I'm hoping that at least the majority of them are more advanced than this. But back then it was just like, you're going to fix the patient, right? You're fixing the dysfunction, and the exercises are an aside. Because for the first 10 years of my career, I would say, well, I'm fixing these dysfunctions that I find in you, these physical asymmetries and strength and mobility. And these exercises are purely to tide you over. I don't know if I would say that, but that's kind of like the impression I would give. If you do these exercises, the improvements you get, maybe you'll keep like 20% of them. But unless you see me X amount of times, we're talking like 20, 30, 40 times. I don't even know how many times people would see me, right? Like back then, I knew every patient's name. Now I'm kind of like, I see patient once every other week, maybe 2 to 3 times tops. And they see me like, "Hey, remember 3 years ago you treated my back?" I'm like, I don't know, maybe. I mean, oh yeah, I see you here in my records, but I don't remember them because I only saw them like 3 times over the course of 2 months. So yeah, I mean, I finished that. I got my DPT. I got eventually I got grandfathered into fellowship, because it turns out at the time the program was so stringent, it was like more than the requirements for fellowship. So I got grandfathered in to fellowship. Incidentally, I also did not pass my manual therapy certification the first time. I don't know, did you?
I was lucky that I did. Yes, I did. I sat in front of the man, Stanley Paris, shaking, and I think I spoke about it in your podcast, but had to recite CO through C3 biomechanics with rotation to the T. And it was an intimidating experience. But yeah, got through it thankfully. But yeah, no, my roommate and my buddy did not pass his first go around either.
I mean, I got questioned, I believe, on 3 things. And you're really allowed to get questioned. Like I didn't outright fail, but I got questioned on 3 things, and I had to fly back like 60 days later just to take those 3 things over. But I made sure I was ready.
Yeah.
And I remember even my mentor said he didn't pass his first time. And he said that, you know what? You pass eventually, right? You're just either ready or you're not ready. So I got my fellowship. I got my MTC. Then I decided I want more credentials. I'm going to just take Mackenzie just for credentials. I mean, now day one, I told my instructor, she's like, why are you doing this? And I said, I just want more credentials. I'm not even going to use this. I just want the credentials. I mean, gosh. And she picked on me, rightfully so. She asked me so many questions. I remember there was like a drill that she did where everyone had to have like a derangement 4 or anterior derangement or like flexion dysfunction. Everyone had it on. You had to like ask what, like everyone would go around and you would ask questions like, so you had to try to figure out what classification you were. And she made me like some obscure classification. Like, I don't know if I was a non-responder or something, like just because I was a jerk, deservingly so. Then I thought, oh, I'm going to take Mulligan now. Now I'm going to take the Butler's courses. Now I'm going to take Institute of Physical Art and learn all about soft tissue work. And every single thing I took, I thought, this is it, man. This is like all my tool bag needs, right? And that's, I think, most people's journey, whether it's manual therapy or not. You just think, well, I'm not getting X amount of my patients better, or I'm not good at knees, or I'm not good at whatever, or maybe I need needling, or maybe I need to learn more about breathing, And so after I took all those courses, I just thought, wow, this is like a really disparate amount of information. Like I had taken and gotten certified in so many different approaches. I had all these letters after my name, and every single approach is like, unless you do it our way to a T, you're never going to get our results. And I'm like, well, how can all these people get results if everything is so wildly different and they're all like bashing each other's approaches, right? Like everyone's like, oh, Paris is like, Mackenzie doesn't know what he's doing, and you got to be specific, and Mackenzie just causes hypermobility, and Mackenzie presents actually a bunch of research that basically says like you can't promote hypermobility, and they present all the palpation based research. It says palpation based assessments are garbage, and they pretty much are. We know that now. And that made my head explode. I didn't want to hear that after I just went through fellowship training. I mean, that was quite a bit of cognitive dissonance. So I started to try to put all this stuff together, and I came up with like a formula in my head. It's like, well, I'm going to do, some soft tissue work, and then if that doesn't make them better, maybe I'll manipulate them. If they give into the informed consent, and otherwise I'll mobilize them. I'll do some neuromobilizations if they seem to have some kind of chronic tendinopathy or radiculopathy that doesn't otherwise improve with spinal stuff. And for home program, I'll always give them repeated loading. And if everything is painful, then I'll use Mulligan, because Mulligan, I used to teach at the university level. Like, Mulligan techniques are great, but only if someone cannot handle your hands. Because one of the rules of Mulligan is like it's supposed to be 100% pain free. But I just thought, that's only for wimps, essentially. And then, so I'm just practicing and moving along. I think I know everything. I think I'm like the best manual therapist in the world. I'm waiting for one of my goals. I always said is like just waiting for all these gurus to die off, so I could become the next guru. I want to be like in the
throne.
Yeah, absolutely. I mean, there could only be one. Not like I have to cut their heads off like Highlander, but I just thought these guys aren't going to last forever. I mean, someone's got to take their place. It's going to be me. So I developed. I remember one time, I ended up treating a chiropractor's son. He saw that I was using like these crude wooden tools, like that the Institute of Physical Art used to promote, like these like knuckle shaped things. You could hold it a certain way and it's supposed to like kind of replicate a knuckle, because they said you either dig in like this or you use this wooden tool. So I used to call them wooden knuckles, and I had a couple of patients who were woodworkers, so they were very crude. I used to say they were like snowflakes because literally every single one was different. They were not like, and they didn't roll off a machine. So he said, "Hey, have you ever heard of Graston?" And I'm like, "Well, what's that?" And so he brings in these tools and he unwraps them, and it's like the way he unwraps them is kind of like you expect it to glow. Like the box in Pulp Fiction. You don't even know what it is. Every time they open it up, it's just like everyone's like amazed and it's glowing. I don't know if it's supposed to be some sort of metaphor or something, but I was like, wow, these are great. And he's like, oh, look at this. You can feel the fascial adhesion. So I was like, well, how much are they? And he's like, they're $3,000. And I'm like, what? So I had another tool who's a metal worker. He's like, oh, I'll make you something simple. I designed my all-in-one edge tool. I used to call it the fauculator because as a joke, I would say that it's coming back from the future to destroy your fascial adhesions. And I started blogging about that. I started blogging about that because I thought I'm going to start selling this online, and that's how I started. I made the manualtherapist.com. I got that domain. I used to ask people like there was like Mike Reinhold, Charlie Weingroff, all these like OGs of the PT world, and I'm like, hey, can you share my stuff? And they're like, I don't know you, bro. Like they hadn't vetted me. I'm to like come out of nowhere, ask me to share my stuff. So I thought, well, I'm just gonna start making so much content that people will share my stuff. Like I didn't earn a share, So I started doing all the edge tool stuff, and I sold thousands of those things at quite a markup. It eventually became called the Edge Tool because Tim Flynn contacted me. He's like, hey, we want to use these in EIM courses, but we don't like the name Faucilator. Like you need to come up with a more professional sounding name. So on Facebook, I'm like, hey, someone come up with a better name. And someone said the Edge Tool goes along with Dr. E, and the eclectic approach. I'm like, oh, okay, everything's going to be E-based. So that's where the Edge Tool came. And then I ended up starting like a e-commerce store, Edge Mobility System, with a bunch of like white labeled different products. And my whole model was to see what's really expensive and bring it to the market at a more reasonable, practical price. So my blog really exploded in popularity for like the first year, and I got lots of shares and lots of likes and everything. And then I got invaded by Soma Simple, and I don't even know if they're around. A lot of like their founders and their biggest voices are still around, and I think that oh gosh, who am I thinking of? Jason Silverdale, who you've had on your podcast a couple of times, and I'm going to have on my podcast for the first time in a couple of days. He basically was one of the people who's just like, hey, you're holding back the profession, and they presented me with all this research, and when you have research, obviously that contradicts everything you believe and everything you've been teaching, you can make two decisions. You can basically say this is BS and never look at it again, which I did for a while, and I argued, and I was like staying up past midnight, like just fighting with these people on my keyboard. And my wife's like, man, are you still like arguing with these like people from this forum? And I'm like, yeah, they're like insulting me. And I'd say a lot of them probably had good comments that I didn't want to hear. But I mean, a lot of it was kind of vitriol and a lot of ad hominem attacks. I mean, like you don't need to lead with you're a dinosaur holding back the profession. You can lead with maybe you should look at this research. I mean, there is what you're saying. And they did say this, like one of the things they would often say, which is I often say in my courses too, like all this stuff works, but it's not for the reason why you think it works. That's a better thing to lead with rather than you're a dinosaur holding back the profession and this is why. But I mean, there was one night where I did critically start to look at this research and I'm like, oh, I think I am wrong. I think I do need to change. And so I started going lighter and lighter with my soft tissue work, with my mobilizations, with my manipulations. I'd stopped teaching the stress strain curve. I mean, St. Augustine's everything. You got to get into the plastic range of the stress strain curve because otherwise you're pretty much doing the patient a disservice. If you're not deforming tissue, why are you even putting your hands on people, right? So yeah, I mean, I still use the edge tool, but I use it more of like as a barrier rather than like if I don't want to touch someone, and I still sell them, but obviously not nearly as much. I feel like that is kind of like the peak was around when I got really popular for the next several years. And now there's a very big anti-manual therapy sentiment. And I think that's also very unfortunate because I think a lot of like manual therapy as the way it's viewed now is like the way that maybe you or I viewed physical agents, right? Because we were thought like, oh, manual therapy is this specialty and it's the end all be all. And everyone who our PT forefathers did all ultrasound and e-stim and that was all just like passive garbage that a monkey could do. And now they're like, well, any monkey could do manual therapy and get results. And that's probably true too. Although I think the monkey doesn't have as much placebo, probably doesn't have quite as much authority, Maybe if the monkey was in a lab coat and wore a stethoscope and the monkey had a degree, maybe you would have some placebo about it. But I think I think it will probably come back around, but I think there's just a disservice, and you and I talked about this on my podcast too, when people are very anti manual therapy, and I think I don't know I know why they're doing it, and I know that exercise should be the goal and an active approach should be the goal, but there are just people who are in pain who are not going to respond to like deadlifts and kettlebell swings and whatever else you're doing, like Turkish get-ups. All that stuff is great if you can tolerate it. Even loading a tendinopathy. Research shows it's okay to load a tendinopathy even if it's painful. Yeah, but it still requires compliance. And if you can make it less painful, and they're more likely to be compliant or adherent. I mean, I don't know what the current word is. To me, it's all the same. If they do it, if they dose high enough, they dose often enough, they'll get better. But if it hurts too much, they won't. If they wait, till your visit, they're never going to get better.
I love the, yeah, I'm in the background here kind of. Now, I'll probably have edited out my chuckles just because I don't like to override the discussion going on, but just one, I get a little flashbacks of my St. Augustine training. And I also echo that hopefully things have progressed and advanced. It's been quite a while since I've been through that training. So I would just hope that things have moved past the immaculate hands and things.
Right.
And, it's interesting.
I always ask though, I don't mean to interrupt you, but at what step of our like 21 step evaluation, because it's like some kind of crazy 21 step, 25 step evaluation. Every time I meet a St. Augustine grad who I'm teaching, I'm like, hey, are they still teaching like the 21 step evaluation? Or like, yeah. And I mean, as recent as like 3 or 4 years ago, they were still teaching this that I'm aware of. But what step did we learn, or when did we finally put our hands on people?
Gosh.
Do you remember?
I don't remember when exactly it is, but I do remember the 21 steps. Now that you say that, it's just
filed. But it was also like, it wasn't even like step 2 or 3. It was literally like 12 or 13. Like, and I don't even remember what the other steps were before that. Yeah. But that is a lot of steps to do before a physical assessment. That is a lot of minutia.
Yeah, I still remember some of the just like outlandish techniques. I remember E2. There was all sorts of things where you're doing all sorts of like interesting things. But again, I can't speak for where that's at right now. But hopefully, as with us all, things have progressed a little bit. I remember Soma Simple. I was around Soma Simple when you were having those discussions, and I was at that point.
Were you in it?
I think I might have chimed in once or twice, hopefully in a respectful way. I don't even remember. I just remember like I was always afraid to comment because there were some pretty loud opinions in there, and some I was kind of fearful to. I had sensed it was kind of, I was in a similar boat as you were as far as like initially getting really pushed in front of me these views of like, yeah, what you think you don't know, and what you think you're doing is really not what's happening. And that was just that was too much to hear at first, and the old cognitive dissonance, clutch to your beliefs, that backfire effect that happens when somebody gets confronted with things that oppose their current belief system. And then same thing, I think I just came around to it like, the evidence was way too strong that there is definitely manual therapy is not as, I don't want to say magical, but is capable of things that we thought it was, the segmental specificity and things you've already alluded to. We've had a discussion online. I don't think you've been a part of it, but there's been a discussion. I put a post up on Facebook and on X, and I'll link it in the show notes here so folks can see the discussion. But about what it means to have good hands, because that has been something that has been something that has very much evolved over time. I used to think good hands, man, I need to be able to palpate that penny through like a New York City phone book. I need to be able to do all these things with my fingertips that are just going to be the reason this complexity that I was seeing in the clinic wasn't getting fixed by me is just because I hadn't honed these amazing sensory apparatus that were my hands that were going to detect these, like you said, these dysfunctions and fix them and get people where they need to be. And that was like a good 10 years of my career, just voraciously pursuing the next hands-on.
You get those 10,000 hours in, right?
Exactly. I mean, I was like, I want to get to those 10,000 as quick as possible. So that was what hands meant to me. I'd love to hear your thoughts on what good hands meant to you earlier in your career and maybe where you think it kind of falls now.
Yeah. I mean, honestly, when I was in labs, just early manual therapy labs, even in ortho labs, I was never one for palpation. I always felt like I don't really know if I'm palpating these things that I'm supposed to be palpating. I'm very much a visual learner, not so much a tactile learner. So for me to feel like, and I don't know why I never looked at my textbooks, and it was the reason why I never quite got as good as grades as I should have, because a lot of my professors specifically had questions that were only in the books, and all I ever did was study off my notes. Like literally, I would sell back my textbooks at the end of the to the bookstore, and I would crack them open, and receipt would fall out. Like they would crack open because I never opened my textbooks. Um, so yeah, I mean, what I thought were good hands were for me to be able to feel mostly the asymmetries in segmental motion, right? The gapping, the approximation, um, certainly to feel fascial adhesions, whatever I'm feeling. I don't even know what I'm feeling at the time. Like in my courses now, that's why I ask, like, are you feeling tone or bone? You know, I used to say bone or tone all the time, but there was one particular juvenile class that I had where I said boner so many times because I kept on saying bone or tone, bone or tone. Everyone's like, he keeps on saying boner. So now I say, is it tone or bone? And because when you change things rapidly, if you really shifted bone like more than a millimeter, I don't even know if we can shift bone a millimeter. If you shifted it like centimeters, like you think, you would actually be rupturing something. And then like what would be the difference between trauma from a like getting hit with a baseball bat and what you just did with your hands? Why do they feel good? Your placebo isn't that strong. You know, you maybe it is, but I doubt it, because physical trauma is physical trauma, right? So yeah, back then I thought, if I can feel these things, plus if I could cavitate any joint I want in the spine within like 2 or 3 tries. Because my buddy, who eventually he went through all of St. Augustine training with me, then he went to 4 years of chiropractic school. He became awesome at manipulation, and I feel like I was only okay at it. And then he just gave me a couple tips, like just practice on your speed, don't practice your force, practice with the med ball, and just like work on your speed, work on the crisp, especially with cervical. It's mostly with cervical because I was pretty good at thoracic and lumbar. So those are my definitions. Feeling segmental mobility, hypermobilities, hypermobilities, feeling for fascial adhesions. Not so much trigger points. I never really appreciated trigger points. I mean, yeah, I used to be able to tell people I can. Like, do you know that movie? What was that movie with Russell Crowe where he would just like look around and he would see all like these relationships between like A Beautiful Mind.
Beautiful Mind, yeah.
Right. I would say, hey, because I would just palpate people on their first rib, like, whoa, man, that's right where it is. Or, find their C5 down glide grade 2 restriction. They're like, whoa, that's right where I need it. And I'm like, yeah, it's like that movie, A Beautiful Mind, where Russell Crowe would just look around, he could see all these relationships. I can look at you and I can see where the dysfunction is. And one patient's like, he was crazy, right? I'm like, well, I'm that, but not crazy. But I guess I was crazy to believe that.
Well, hey, I honestly, talking to you, I feel like I'm at an AA meeting where, like, hey, my name is Mark. I'm a recovering old school manual therapist, and and we're just like rehashing. I did it on your podcast. You're doing it on mine. But so let's go into good hands, because I think you've done a good job.
I think there's still a good hands.
I agree. Tell us what your thoughts are on it.
Right, and I think there's still like the lost art of manual therapy would be that you even place your hands on people. I remember one of the differences between Butler and Mosley was that, and people don't realize this, I think, because they think they're just both big pain science guys, is that Mosley's background is like in motor control and whatever exercise, but he was never really a manual therapist, versus Butler was a classically trained manual therapist like you and I. So I remember well after sensitive nervous system came out and David Butler started teaching Explain Pain all around the world, he used to have that blog, was it NOI Jam or something? It was great, right? I used to love that. And he just posted this really simple case where he said that, in the middle of like Explain Pain residency or something, wherever he had a bunch of people mentoring at his facility or his hospital, wherever they were in Australia. He said that everyone was trying to talk this woman's pain out, and of course do all this education, use metaphors and all the stuff we're supposed to do. And he came in and just said something like, put his hand on her shoulder, like everything will be okay. Or, and she's like, oh, no one had ever touched me before. And you finally touched me. And I thought my body was so fragile. It didn't matter what all you guys were saying. I just thought I was so fragile based on my scans. And that's where he said, like, there's still such a power to touch. If someone is that fear avoidant and they feel like they're that fragile, there is something to even this, like the comfort of touch. So I think that is like the beginning of the art. And the guy who actually told me about Stanley Paris, who was like the hospital supervisor at one point, he eventually became my fellowship mentee because I got fellowship before him. And then he formed his own practice, and I was like a practice within his practice. And this guy is the nicest, like most charismatic guy you'll ever meet. Not so much into pain science and doesn't really like all that kind of like non-pathoanatomical things. But since he was just so nice, like he just had, I just call him like the PT concierge. Like if that was his brand, someone would be like, oh, in the waiting room, he would just go see people. And often he was like 20 minutes late. He was just like always chatting and whatever. So he, someone who's like high fear avoidance. I just remember seeing him do this. She didn't even want to be touched. He was like walking her back to the eval room. She's like, oh, I have a really bad disc herniation and I just, I'm so afraid to forward bend. And he's like, oh, here, I made you hot chocolate in the Keurig, and he put his arm around her. He's like, I got just the thing for that. He just led her into the eval room. And that was it, And just the thing for that, I think, is like just a little white lie that a lot of people need to hear, because I know that this was a podcast. This was like someone asked this on Twitter. I think it might have been Andrew Rothschild, like my podcast host. He said, like, how do you feel about people who need to hear a pathoanatomical explanation? I'm like, I have no trouble telling them a little white lie. If they're like, hey, I have a really bad disc herniation, I'm like, these exercises are really good for that disc herniation. Even though in my head, I think by really good, I mean just desensitizing your system, as opposed to whatever, putting the jelly back in a donut, So I think like part 2 of good hands is knowing when to put hands on people and when not to put hands on people. And how do you do it? Like the skill is using it in a way to desensitize the system, but also explaining that this is not fixing you. This is going to temporarily reduce the sensitivity of your loading strategy, your activity, your position. We're changing that neurotag temporarily, and I'm going to give you something to capitalize on that and to keep that desensitization going. Right? I'm not fixing you. So I think that's the skill, and also again, just not causing pain. There's some things that maybe have to be painful, like a shift correction. Because I think if someone's laterally shifted, lumbar lateral shift, you need to do that shift correction. But I think, not causing pain, not thinking you have to be specific, but also knowing when to do hands-on, when not to do hands-on. Yeah.
Just that communication or the hands-on has, like the confidence, it hopefully engender the trust, the relationship building, like your colleague had demonstrated there with the hot chocolate and arm around the shoulder. I'm not saying we all need to do that. That may not be our, personalities for all of us, but I do think hands-on, just, again, it doesn't need to be this paralysis by analysis. I'm identifying like a faulty car or things in alignment, but I do think there is some benefit of one, being able to like lay your hands on to respect the sensitivity of somebody, because you're not like a bull in a china shop just blasting through it. You're not awkward with how you're explaining it, where the person like, this dude's creepy. Where you explain it in a way that engenders trust and confidence, and you apply it in a way that responds to the unique sensitivity and response to that system underneath your hands. And and again, I don't think it needs to be all that magical, but I do think there's an art. I mean, somebody on my Facebook thread had talked about we've all had like a bad massage therapist where a good one, man. It's like they're playing your body like an amazingly well-crafted instrument. And some folks are like, that first person who's first getting on the piano and just like pounding the keys, like where it's just uncomfortable. So there is that art of it. I mean, I don't think we've obviously fully even understand all that, but the physical communication of your hands to hopefully engender a sense of trust and hopefully build a movement confidence when you're starting to passively move a body part that you want the patient eventually, like you said, to take over and actively move it. And if you can desensitize it passively in a way that, hey, no, actively I'm able to move it, and explain it in a way that doesn't make them think that only way that this thing is going to feel better is if Dr. E lays me on that table and nudges on my back for a good 15 minutes. And I think we've all been there in manual therapy jail with people where it's been like, 24 visits and we're still doing the same soft tissue technique and the same nudge on the back. And they keep coming back happy as a clam. Nothing changing outside of the treatment room, but man, they love it inside the treatment room. But yeah.
I always say that every clinic has their lifers, but you don't want 80% of your business to be your lifers, Yeah. Every clinic has like the patient that's been there so long, they can show the other patients how to do their exercises.
Yeah. I've worked with folks where, man, they're working on the same people they've worked on for years and years. Maybe they take a month or two or a year break, but it's the same thing. It's interesting where, we can build these practices. And I know I did for myself where you just build this like sea of confirmation bias around you because all you got to be folks that just, are singing your praises.
Everyone just says you're great. You got magic hands, Mark. Magic hands.
Yep. You have a gift in your
hands. Oh, right, so. Man. I used to love magic hands, and now I hate magic hands. I used to love it, man. What a great ego booster that is. It's for someone to tell you have magic hands. And now when someone says it, I'm just like, oh, cringe. Oh,
yeah.
Did you not hear what I was saying?
You bring up something that I think is worth talking about because we touched upon this a little bit in the podcast from my perspective. And I know you touched upon it in your experience as well, but the whole ego shift that happens as you kind of have grown and recognized our limitations with, our skill set. And like, again, the analogy and things everybody that we like to throw out there is, we wanted to be Batman earlier in our careers where we're freaking swooping in, saving the day, throw up the bat signal of pain, and we're going to go and like knock it out. And then realizing that our role is probably more the Alfred. I know you had alluded to, like, you feel like sometimes you're more of a coach than you are like a clinician at times to help people out of their situations. But I'm wondering where your ego had to go. I know for mine, I had to go away from this like need of like being important in the equation and the hero of the story to that supporting role. I'm curious what your experience was with that.
Yeah, I would have to say that was one of the biggest shifts because I thought I had like these super gifted hands. And even though I still think I'm good at manipulation, because when I teach manipulation, I realize, and I'm sure if you've ever taught manipulation, you've seen and people like, you might never be able to do this. Especially cervical. That's what I'll say. Like cervical is like the great equalizer. You can be like a super small ectomorphic 90-pound girl or like a 300-pound guy, but you're not going to be able to muscle your way through a great cervical manipulation. Like you need finesse with this, but anyone can muscle their way through like thoracic and lumbar, So, oh gosh, I just derailed myself. What did you just ask me again?
I was just saying like how the ego shift of like,
oh, right. Yeah. So, I mean, going back to that cognitive dissonance, I had to just realize that I wasn't doing all these things. And I really went back and took a big look at most of my McKenzie training. And then I started mentoring in fellowship that was when around the McKenzie's time, like 2 years after I started blogging and I started having these slowly shifting. Obviously this wasn't overnight. The McKenzie Institute through my mentor said, well, we want to be part of the AOMPT. So we want route to fellowship for our diplomats. So I started mentoring some of these McKenzie diplomats, and a bunch of them were in my practice on and off, and I'm just doing all this mobilization, and patients are like getting better, not better, and they're like, oh, hey, let me just try this. And I remember a couple times there's like a shoulder patient or a knee patient that I'm just struggling with, and they're like, oh, let me just try this, and it's like repeated knee extension, open chain, or repeated shoulder extension, like passively. And I remember saying like in my head, like, well, that's the dumbest thing I ever saw. And the patients, like both patients, were so much better, so grateful to this McKenzie diplomat. And the guy who I was training is like, I'm going to give up manual therapy after seeing that. And I'm like, you don't give up manual therapy. But I mean, that really, after I saw it so many times, I just thought there is something to this MDT. And that became I started shifting more and more to, this is going to be primarily my home program as opposed to use this and stabilization and whatever else I was showing at the time. I don't even know what. To now this is going to become the majority of my treatment. And I only put my hands on to get them to be able to do MDT, repeated loading type strategies. So yeah, that was really hard. I mean, it was hard to give up that confidence. And then the more research I read, the more I realized that all these things work. We still don't really have a great idea why they work. I know Chad Cook recently has presented some research that I still have yet to read about. Maybe there's more chemical mediators rather than just pure changes in perception. But if that were true, I still think, like, why does it change so fast? Like, even when I have a headache or something and I take an ibuprofen, like I try all those retractions, I try all kinds of natural, like movement to base things. And I'm like, I'm just going to finally break down, take an ibuprofen. Now I take turmeric, but I used to take ibuprofen. I would feel better, like almost within a minute of swallowing it. And I'm like, I know it's not better. Like, why? I'm skeptical. It's not like I just believe in it so much. Like, why does it work that fast? I don't know. And I meant to ask you this too, because I've been meaning to ask someone this. What do you think the mechanism is when someone gets like one treatment for severe pain and they're better and they never did their exercises?
Yeah, I think it's a shift, top down. Personally, like it was just enough of something that built their, be it implicit, like below the consciousness or whatever, that little hindrance or apprehension or kind of fear avoidant kind of behavior on that spot, that it was just enough to say, I can shove this thing in the background because I know I'm confident that I'm safe to move. And I mean, that's probably, I know some people are going, oh my God, that's not, but
well, I mean, what else could it be?
Yeah, I mean,
right?
there's obviously, we know mechanical changes aren't behind that, and different things, but you'll hear those, like, and we've probably all had them in practice, like these, like
like one adjustment,
miracle
or
cures.
one cortisone injection, or one whatever, and then they're 100% better forever. And I didn't even bother doing the exercises.
I've had some folks come in on their second visit, like, they got cookies in tow, and they're like, "Oh my God, I've been pain free for the last week and a half. I can't thank you." And I'm like, I'm just looking at my notes. I'm like, what did I do to this person? Because I'm like, there must have been something I'm forgetting that I did. And it was nothing out of the ordinary. It was, whether it be a basic mob or sometimes it's like a McKenzie, repeated load thing. And like, boom, like, again, just like massive, like 180 in life type changes. But yeah, I definitely think there's more to it than obviously the mechanical. We know that it's definitely more than that. And even, placebo and all these things. I think we're still figuring that all out, but it's fascinating stuff to think about what is behind those changes for sure.
Yeah, I don't know. I think I just look at it as like the right explanation at the right time. All these planets align such that there's literally, you just eliminated. They went from 100% threat to 0 threat.
Mm-hmm. Yeah, no, that makes sense. That makes sense. I mean, I remember back in the day, I would have told, oh yeah, man, that was that. It was that mold, man. I perfectly locked out that C2, and man, that thing popped and cavitated like it's never.
Yeah, and then no more positional fault, back in place, everything all aligned, that stable now.
Left sacral torsion is eradicated.
Oh man, that's the worst there.
The SI
sacrum is the worst.
That gives me the most headaches of my prior manual therapy training. It gives me like shivers, and I still work with close by in proximity a lot of traditional OMM practitioners, and I still get like PTSD when I see some of the notes that come through and some of the narratives. But some professions are struggling to move forward other than others. We have our own issues, obviously, in physio as well. But man,
the problem is that they're successful, right? There's a problem with any manual therapist. I mean, the confirmation bias is strong, right? Oh. The more successful you are, the less you need to think that you need to change. I was successful.
Yeah. And that's
I got people better.
And that's a struggle I see with like osteopath. I never see any osteopathic folks drifting out. They are very a tight knit group in their OMM like conferences and stuff. They get no reason to challenge their beliefs because they're surrounding themselves by like a massive dose of confirmation bias and
and they're still all in that type 1 and 2 lesion and FRS
groove
and ARS
dysfunctions and leg length discrepancies. Everybody's got pelvic asymmetry and all these different things. And and again, you're right. These people get better, and the problem is we don't zoom out and say, well, what's behind that? And then I remember John Child sharing a story about how he would like challenged his OMM background or his osteopathics. He was trained a bit in like MET and went and purposely treated the opposite of what the positional faults would say. So if this person was ERS left, he further jammed it in the ERS left with a technique that was aimed in that direction. And lo and behold, test, treat, retest, people were still having positive changes. So it kind of was, his thing. And I started playing with that in my clinic. I'm like, dang it, he's right. Because these people are still like, if I go with the positional fault, supposedly that my magical hands are identifying, or I go against it, I still make positive change. So yeah, it's interesting with that.
Yeah, not too many people were brave enough to do that.
Yeah, I mean, I remember hearing like, gosh, Amy Eicher is a PTA good friend who's gone through a hell of a journey getting SI fusions and stuff. She had her PT come to join her on a surgery to fuse it, so that she made sure she went into surgery, aligned. So the surgeon.
Oh, she had to be aligned first?
Yeah, before the surgeries. Yeah, she was like, and she's reformed from that thought process, but she tells a story of a osteopath who, was assessing her pelvis and back. She's got back pain, and she said, pathologizes her SI joint, and she's like, well, it's fused, it's not moving. And the osteopath, instead of saying, oh, maybe I'm wrong, maybe my hands aren't, you need to go to the emergency department right now because your fusion has failed. And like, it was just interesting, like how gripped onto our belief systems. And
well, I mean, at least she thought of something,
yeah.
I mean, I have two stories about this actually. My podcast host, Andrew Rothschild, before he was a PT, I don't know if he was doing personal training or whatever. I know he has a background in kettlebells. He had some pretty severe low back pain. He ended up with a fusion, lots of hardware, multi-level fusion. I think at least like 2 levels, 3, or maybe, I mean, by 2 levels, I mean L4-5, L5S1, I think. And went all the way through PT school. I mean, his pain was better. He got back into kettlebells, he's very, very fit. And then he just decides, like, after learning about pain science and everything, and also being exposed to my blog and eventually like coming in contact with me, he's like, well, I'm just gonna, out of curiosity, I'm just gonna see what does my back look like on a scan. And he posts this in all his courses now too, because he teaches like my pain science version, like under my brand, Eclectic Approach,
Sure.
Modern Patient Education. All his hardware is all busted up. It's like all broken. He has like floating screws and everything, and he has no pain. He's like no longer I don't know if it's like natural fusion, but I mean his hardware is just like just all jacked up.
Yeah, and I mean, if that isn't like the example of treating the human like a machine with the fusion of, I mean, again, there's maybe a time and a place, of course, but that surgery obviously has run away from the evidence horse a little bit. Yeah, man, we could talk forever on this stuff. I know you're busy. You got family today. This is your day off. I appreciate you spending some of your time with us today. I know I benefited from the discussion. I'm sure folks out there, if you feel like this episode was like an AA meeting of recovering manual therapists, maybe you feel like a recovering manual therapist.
Yeah.
And again, hopefully you don't hear that manual therapy is a terrible, horrible thing. It's just hopefully you've reconceptualized what it means with hands-on and what it's capable of. But maybe, especially if patients value it, that there's still some value involved in putting your hands on somebody and helping them gain confidence to start moving, especially independently in their life. If that's the gateway to it, then I have no issues doing that. But anyway, we'll wrap it up with that today. Erson, thank you again for your time.
Yeah. Hey, wait a minute. At Modern Manual Therapy on Facebook, Instagram, and YouTube.
Yes, we will link this all up on the show notes so you can check out Dr. E and all his awesome courses and things on that. Make sure you check out the PT Podcast Network as well, because that's where our podcasts are all hosted.
Part of the PT Podcast Network.
Yeah, we're trying to push each other up and spread the love on the podcast in the PT realm, because there's just a lot of people that need to hear some of this stuff. And maybe some people are recovering manual therapists who need to have a vent session that they listen to and like been there, done that. I know the feeling. So share it with them. We'd love to hear their comments and different things on that. But we'll leave it there this week. Hope you guys enjoyed the episode. We'll talk to you next week.